Assalamu alaikum. I welcome you all to the result announcement session of the oral presentations and e-posters presented in the ICON 2022. To begin with, we received around 90 abstracts in this ICON, and these were reviewed by the scientific committee, out of which 36 were selected as e-posters and 11 were selected as the oral presentations. We had a panel of three judges. Who selected the best three e-posters and best three oral presentations. The judges panel included Professor Dr. Salman Imtiaz, who is the current head of the Department of Nephrology and chairperson nephrology Indus Hospital and Health Networks. He has many research papers under his name. Dr. Farhana Amanullah, who's a pediatric nephrologist with over 20 years clinical and research experience with us. Dr. Quratulain Sheikh, who is an FCPS internal medicine and MSc epidemiology and biostatistics, currently working as an infectious disease fellow at Indus Hospital and Health Networks. She has served as a reviewer for international journals besides publishing several peer-reviewed papers. Let's have a look at the oral presentations we received in the ICON 2022.
Dr. Anam Arif. I'm Senior Fellow Vascular Surgery at Combined Military Hospital, Lahore. It's a pleasure to present today on this platform. Title of my presentation today is Acute Limb Ischemia and its Fate. Acute limb ischemia or ALI is a limb-threatening condition. It's a surgical emergency. Although the incidence of ALI is known worldwide, it is highly underreported and misdiagnosed in Pakistan. Patients with ALI should have their revascularization done within 6 hours of incidence. It is mentioned in literature that ALI has 6 Ps and the diagnosis should be done on the basis of 6 Ps. But we want to tell here that diagnosis of AL on the basis of completion of 6 Ps is highly not recommended. The only important P is pain out of proportion. If you look at the pathogenesis of acute limb ischemia, you can see that the first event is pain out of proportion. This is followed by loss of sensation and then motor loss. There comes a stage of skin changes in which the skin initially turns pale, then dusky, and there is some thick staining. Finally, the muscle tenderness become evident. So, if the patient is diagnosed and treated at the stage of pain out of proportion, the chances of limb salvage are very high, and they gradually decreases when the patient is managed at later stages. Here is an image of a patient who was referred to Department of Vascular Surgery after 2 days of being managed of his lower limb pain as muscular strain by his primary physician. He was referred to us when there was this skin discoloration of the limb. At that time, nothing much could be offered to a patient because the skin changes were only evident and revascularization was out of question. In Pakistan, vascular surgery is in its initial stages. It's in infancy right now, and there are only a small number of trained vascular surgeons in the major cities of Pakistan. This can be evident from the fact that the Department of Vascular Surgery at CMH Lahore is the only center in southern Punjab that has certified vascular surgery department. The department is led by a professor, an assistant professor, and 3 fellows, and they receive a very high influx of vascular surgery and particularly ALI patients from the surrounding cities. It was because that we received patients mostly late. We decided to conduct this study to evaluate the causes of late presentation of ALI and its impact on final patient's outcome. This pilot project underwent in the Department of Vascular Surgery over a period of an year. All patients of ALI were categorized into early and late group because of a cutoff of 6 hours. It was seen that in inclusion criteria, patients with either gender aged between 20 to 80 years and a clinical suspicion of ALI were included. Patients with acute or chronic limb ischemia and previous intervention at referring center were excluded from the city. So a total of 61 patients were recruited in the study. There was also seen a male predominance. ALI in the lower limb was twice as common as in the upper limb. Atrial fibrillation was the most frequent cause of ALI as reported in literature, but an interesting thing we found was that in 3 patients, the cause of ALI was COVID-19. Other than Lahore, we received patients from the surrounding 13 cities, more frequently from Multan, Faisalabad, and Rawalpindi. It was very unfortunate to see that only a minority of patients, only about 5 of them, could present within the critical 6 hours window to the hospital. Whereas it was very sad to see that only 3 of them could reach to the vascular surgeon within the 6 hours window. I want to stress here that reaching to a vascular surgeon in 6 hours is more important than reaching a hospital, because there will be some time wasted in contacting a vascular surgeon, taking the patient to OR, getting the consent for surgery, and this will all delay the final management of the patient and the final outcome will be impacted by it. The most desirable mode of presentation is vascular surgery emergency, but sadly, it was only evident in less than half of the patients. On interviewing the patient regarding the cause of delay, 33% of the patient reported that they were late because of a combination of late presentation to tertiary care hospital and a delay to reach a vascular surgeon. The next most important cause was ignorance of the patient. There were some patients who had some financial constraints and transportation issues also. There were some patients also who reported to the primary physicians urgently and immediately, but the diagnosis was missed by them and they were very late referred to a vascular surgeon after their limb skin changes were evident. The initial management of the patient was divided into 3 groups. The most desirable management option is embolectomy, but it could only be offered to 10% of the patients. Primary amputation was most common and offered to 31% of the patients. There was a subgroup of patients who were managed conservatively. These are mostly the patients of ALI with upper limb ischemia. And literature has shown good outcomes in management of ALI in the upper limb. Final outcome as 30 days was followed. It was seen that limb salvage was possible in 34% of the patients. There was a subgroup of patients who died within 30 days, even after prompt management, because of the overall health of the patient. Here we want to stress that ALI is not only limb threatening, but also a life threatening condition if not managed on time. The final outcome of the patient was further categorized into early and late group, and it was seen that in all 3 patients who presented early and was offered embolectomy had their limb salvaged, whereas it was only possible in 31% of the patients in the late group. All 3 patients with COVID-19 underwent amputation eventually. Even one patient had mortality because of the overall health condition of because of COVID-19. We want to stress here that ALI is highly underdiagnosed and underreported condition. It is partly because of the lack of awareness of the general practitioners and also because of scarcity of trained vascular surgeon in the country. Delay in presentation and revascularization not only result in major limb amputation but also mortality of the patient. Loss of a limb of a breadwinner affects the economy of the family adversely. A recent study in Karachi reported the incidence of amputation in ALI as high as 60%. This is somewhat higher than reported in our study. Acute ischemia is managed with emergency embolectomy. This is a small procedure, takes about 30 to 40 minutes, and is performed mostly under local anesthesia. Clots are retrieved surgically as seen in image 2, and successful retrieval of the clots makes the chances of limb salvage very much high. In conclusion, we want to stress that education of general practitioner is very much important so that patient can be timely referred to a vascular surgeon. We also want to stress here that the patient should be referred to vascular surgeons on clinical suspicion and not on completion of 6Ps and not on any radiological confirmation. In the end, more trained vascular surgeons and equipped centers are required so that the optimum management could be offered to the patient on right time. The best time to refer to a vascular surgeon is when the limb looks perfectly normal as seen in image 1. When the skin changes has become evident as seen in image number 2, when the skin changes are already there, the blackness has been present, the skin mottling is done, nothing much could be done, and limb salvage is out of question. Thank you very much for your time.
Assalamu alaikum. My name is Dr. Zahiruddin, and I am working as an assistant professor in infectious disease department at SIUT hospital. And today, the topic of my presentation is outcome of COVID-19 in renal failure and tolerance of remdesivir, experience from a large renal and dialysis center in Pakistan. Patients with renal failure are at increased risk of progression to a severe form of COVID-19 with high mortality, 25 to 30%. Whether remdesivir increases the risk of AKI in patients with COVID-19 is still uncertain. Remdesivir is not indicated in patients of severe renal impairment unless benefits outweighs risk due to scanty safety data. So here I would like to share some work done previously, and this was a study done in India by Thakkar et al. Reported no significant renal impairment with remdesivir in patients with AKI or CKD, but limitation was numbers were few and no controls for comparison. Another study by Pathogenesis et al. From USA, a single-center comparative study on patients with severe renal impairment found to have serum creatinine elevation in 27% versus 11% in control group, not statistically significant between the two groups. Another study from Italy, a retrospective observational study, 109 individuals, also did not find any significant renal impairment who patients who received remdesivir. So our aim and objective were to evaluate the outcome of patients with renal failure who received remdesivir in terms of mortality, and to study the safety of remdesivir, especially in patients with compromised renal functions. So this was a retrospective observational study from June to November 2020. We included all patients more than 18 years with COVID-19 having saturation less than or equal to 94 and received remdesivir. We excluded transplant recipients. Patients were divided into renal failure and non-renal failure group. Demographic comorbidities, inflammatory markers, and ICU stay were compared between the two groups. Renal and liver functions among patients were observed at day 0, 5, and 7 of remdesivir. Our primary endpoint was mortality at day 28 and adverse effect from remdesivir. And our secondary endpoint was to find out the risk factor associated with mortality between survivor and non-survival in renal failure group. Overall, we had 142 patients receive remdesivir. Out of those, 38 in renal failure group and 104 in non-renal failure group. Mean age was 55.93, and no difference were observed between the two groups. But in both the groups, the patients were elder, more than 45 years of age, as compared to younger patients. There was no any significant difference regarding the gender. Male were 63.2% in renal failure group versus 66% in non-renal failure group. But when we saw the coexisting medical conditions, what we found out that 84.2% in renal failure group have comorbidities other than renal failure, as compared to 60.6% in non-renal failure group with a p-value of less than 0.008. And more patients in renal failure group were hypertensive, 68.4% versus 30.8% in non-renal failure group with a p-value of less than 0.001. Regarding the symptoms, the fever was most common symptom, followed by cough and shortness of breath, but we did not find any significant difference between the two groups regarding the symptomatology. This was the table showing laboratory parameters on admission. And these are the median laboratory values, and we found out that CRP was 12.5% in the renal failure group versus 7.6%, and ferritin was also high, 1180 in renal failure versus 431 in non-renal failure group with a p-value of less than 0.001. And D-dimer was also high, 2.52 versus 0.64%, with a p-value of less than 0.001. Overall, 24 patients were died, comprising 16.9%, and 28.9% in renal failure group and 12.5% in non-renal failure group died with a p-value of less than p-value of 0.021. When we saw the risk factors of mortality in renal failure patients, we did not find any significant difference regarding the risk factors of mortality, the gender, comorbidities, laboratory parameters, and treatment. We did not find any significant difference between the two groups. This was the median serum creatinine in renal failure and non-renal failure groups, and we can see that in renal failure group, the median serum creatinine was 4.59 on admission, and it came down to 3.92 at day 5 and 3.87 at day 7. While in non-renal failure group, the median serum creatinine was 0.88 and 0.94 at day 7. This was the 6-point ordinal scale in non-renal failure group, and we can see that 55% of patients were on a room air on admission and 39% on oxygen. And on day 14, 83% of patients were discharged, while 12% of patients died at day 14. In renal failure group, we can see that 63% of patients were on oxygen on admission, and at day 14, 63% of patients were discharged, while 5% of patients were still on oxygen, and 6% of patients were died at day 28. Oh, sorry, day 14. So in conclusion, COVID-19 in renal failure patients with severe disease carrying high mortality, coexisting medical condition, and raised inflammatory markers on presentation more frequently found in non-survivor renal failure patients. In our cohort of patients, remdesivir was well tolerated and no patients required discontinuation of drug. Remdesivir did not increase the risk of AKI in hospitalized COVID-19 patients. Thank you.
Assalamu alaikum and greetings to all. I am Dr. Amir Hussain, currently working as medical officer in Government of Sindh. I am also doing fellowship in Field Epidemiology Laboratory Training Program of Pakistan. First of all, I am very grateful to Indus Hospital Icon 2021 to give me opportunity to present my abstract, which is regarded an outbreak investigations of measles during the pandemic of COVID-19 in District West Karachi 2021. The story began when on 12th January 2021, there is sudden rise and surge in suspected measles cases, and with one death, unfortunately, to DG Health Office at Hyderabad. After confirmation from local authorities, we have declared an outbreak in the area, A team was formulated with the help of 2 FELTP fellows and deputed immediately to the local area to investigate and identify the risk factors of that disease and to provide control and prevent outbreak of measles in the community. We have chosen the descriptive case control study for this measles outbreak investigation in District West Karachi. We have formulated a case definition according to the scenario. We have taken a case as which shows that there is a sudden onset of fever, 38 degrees centigrade or greater, and with maculopapular rash, which is non-vesicular in nature, among any child who is below 15 years of age and a resident of District West Karachi from January 1st to August 31st, 2021. We have used a case reported pro forma, which is modified to gain the information regarding demographic features, clinical signs and symptoms, immunization status, contact history, morbidity, mortality status. Additional information was collected with review of our hospital records, active case findings, contact tracings, and face-to-face interviews. Finally, statistical analysis was conducted with the help of Excel, Microsoft Excel and EPI Info version 7.1. In our finding, the median age was 23 months with the range of 6 months to 171 months. The male to female ratio was 2:1. The majority of the participants were male children, and the overall attack rate was 13.83, almost 14 per 1,000 population. The case fertility rate was 0.55%. Fortunately, there was only less than 1 case fertility rate. And however, unfortunately, majority of the cases, almost 67%, were unvaccinated. Figure 1 shows that the majority of cases belong to age group 13 to 24, followed by 25 to 36 months, and the least cases belong to 133 to 144 months, and only 2 cases were reported among the age group of 169 to 180 months. The District West is comprised of 5 towns, which are Khemari, Said, Orangi, Gadab, and Baldia. The majority of the cases were reported from Orangi town and followed by Baldia town, 197 and 119 respectively. Figure 3 showed that all the cases were presented with rash and fever. However, 11% showed that there are some upper respiratory tract symptoms like cough, flu, etc. In case control study, we have calculated odd ratio. The odd ratio was 0.39, which is below 1. With the 95% confidence interval, the range was 0.34 to 0.45, and the p-value was less than 0.001. So the results were highly significant, and the odd ratios showed that the vaccination was the protective factor, and the majority of the children were unvaccinated, and this was the reason that measles outbreak happened in the area. So we have recommended and concluded that accumulation of unvaccinated children in the area was the main factor of this outbreak. So the outreach and mobile vaccination activities, especially during lockdowns of COVID-19 outbreak, should be strengthened. Further health education and public awareness should be enhanced among the community members. And finally, last but not the least, local health authorities should take strategic steps to counter future outbreaks. So government has taken the action, and in coming months, there is measles and rubella vaccination campaigns. So thank you, everybody. Questions are welcomed.
Assalamu alaikum. My name is Dr. Wasfa Farooq, and I will be presenting my abstract titled Establishment of a Multi-Institutional Childhood Cancer Registry in LMIC. The World Health Organization launched a global initiative for childhood cancer in 2018 to achieve at least 60% 5-year overall survival for children suffering from the 6 most common childhood cancers by 2030. The current overall survival rate of childhood cancer in Pakistan falls somewhere between 30 to 35%. Unfortunately, national action plans remain missing despite resolutions, as major misconceptions persist worldwide. Not only is the burden of cancer in lower middle income countries incorrectly perceived
Assalamu alaikum. My name is Dr. Shazia Musa, and I'm the Deputy Manager, Safe Circumcision Program. On behalf of my co-authors and myself, I'm really happy to participate in ICON 2022, and I'm presenting my paper, my program paper, which is implementation of an infant male circumcision program in Pakistan. This was published in the WHO Bulletin in February 2021. So a bit about a background about my program. This was established in February 2016 as a service delivery program aimed at mobilizing and training community health providers to provide safe circumcision to male babies within 3 months of birth. So globally, approximately 1 in 3 males is circumcised for religious, cultural, or medical reasons. 68% of circumcised men are Muslim. Pediatric circumcision is also considered for HIV prevention. Choice of the provider depends on many things like family preference, religious tradition, cost, availability, and perception of service quality. However, circumcision by non-medically trained providers is definitely cheaper. Now, WHO recommends that early infant male circumcision be a primary task of non-physician healthcare workers like midwives, technicians, and those countries who have enough physicians and specialists, then they could use them for circumcision. But we see that the contrary is true for developing countries, as there's a serious shortage of healthcare providers. Standardized operating practice should be there for circumcision, according to WHO, including the management and reporting of adverse events. And methods to improve training and practices are urgently needed to avoid unnecessary complications. Circumcision is a simple surgical procedure, safely performed by a trained person. Literature review shows that results have shown to be equally good whether performed by a surgeon or a trained health provider using full sterile precautions. Where there's lack of formal training programs, lack of uniform policy, and lack of adequate equipment and resources, then complication rates as high as 20% have been reported in studies. And untrained providers create more complications, regardless of the fact that they are technicians, nurses, or qualified doctors. So, looking at Pakistan, there are 3.2 million male babies that are born in Pakistan annually, and 99% will undergo circumcision due to religious reasons. However, it is seen that there are only 200 registered pediatric surgeons in Pakistan. And if they circumcise babies day and night, there still will be a critical shortage of procedures being conducted. The real scenario is that 90 to 95% of circumcisions are actually performed by barbers and religious providers who are untrained and not following any kind of sterile procedures. Reported complication rates up to 16% in a local study have been found where 200 infants were circumcised at a military hospital. So, with this perspective, the Safe Circumcision Program was established, and the WHO Manual for Early Infant Male Circumcision under local anesthesia that was sort of formatted in 2010. That was used as the main reference. So I would like to talk here about task sharing. Now, what is task sharing? Task sharing is rational redistribution of work where highly specialized tasks are sort of delegated to less specialized providers so that the specialists have time for more complicated tasks. This is a concept that is being endorsed by WHO and being followed by many developing countries. It is also seen that early circumcision is associated with lower cost, less complications, quick recovery, and easy handling. There are many techniques, but Plastibell has been found to be simple, safe technique and is associated with low complications. So this is what we adopted. So Safe Circumcision Program was piloted, and it is at the Sheikh Saeed Hospital, which is the Obs and Gynae department of the Indus Hospital, and it is a program that is led by health workers. So the aims of the program were to promote early infant circumcision, to provide safe sterile circumcisions to male babies within 3 months of birth. We started with 2 months, which was recommended by WHO, and then we extended the time to 3 months. Then to train health providers, to monitor the outcomes closely, and to scale up first to IHM facilities and then to community-based facilities. For this, we started developing the tools. So we developed the training manual, the parent information, and the post-procedure care brochures. There was a detailed enrollment form, posters, standees, and an animated video was also constructed to disseminate information regarding early circumcision. So here's a sample of the standee that was used and the posters, and these are the parent information brochures that were used to counsel families before the procedure. And these were the post-procedure care brochures which are used to educate families regarding how they could care for the baby after the procedure. So the eligibility criteria that we decided upon was that the baby should be healthy, age should be less than 90 days, he should be a term baby, his weight should be more than 2.5 kg, no congenital penile abnormalities, no blood dyscrasias or family history of bleeding disorders, and an informed consent signed by the parent or the guardian was absolutely essential. So here is the flow chart for inclusion of babies in our program. You can see that in the study period, there were 4,270 male infants that were born at the Indus facility. When we talk about Indus facility here, we mean Karachi, Sheikh Saeed Hospital, and Muzaffargarh, the Indus Hospital in Muzaffargarh. So during the study period, these many infants were born. 80% nearly, or 80% of the parents of these babies were cancelled. 700 infants were excluded because either they were underweight, unwell, they had abnormal genital screening, or their parents refused to have their babies circumcised. Then you can see that more than 700 babies were also brought who were born in other facilities other than in this hospital, and their parents brought them to get circumcised, to have them circumcised through our program. Then nearly 3,620 infants were given appointments, and the babies that turned up for the appointments were 2,849 who were then circumcised. Out of these, 27 babies were circumcised by pediatric surgeons, so we've excluded them from this study. In this graph, you can see the blue bars represent monthly procedures being conducted in Karachi, and the green bars represent monthly circumcisions in Muzaffargarh. So you can see that in December 17, the clinic at Muzaffargarh started off. And till the end of the study period, 2,849 circumcisions have been performed. So have a look at the complication rate, where you can see and appreciate that the major complications that happened were only 0.3%. And the main sort of out of the total of 4% complications, 3.78 were actually minor. And most of them were bells getting impacted after the procedure. So the Safe Circumcision Program achievements that I've sort of compiled here are that the tools were developed in-house. We have 2 sites operational at Karachi and Muzaffargarh. We've trained health providers to perform safe circumcisions. We have managed, alhamdulillah, to have a low complication rate, and our program paper was published in the WHO Bulletin. So this program is currently still running at both the facilities, and I'd like to share the recent data till October 2021. And it can be seen that up till now, in these 2 facilities, 15,800 babies have been delivered at both places. 13,400 plus mothers have been counseled. The number of procedures, circumcisions that have been performed through our program are 12,200 plus. And 0.9% has been the significant complication rate. Thankfully, there have been no reported serious adverse events. 99.8% satisfaction with the parents, and we have managed to train 20 health providers to perform safe circumcisions. So the way forward from here is that we want to target more babies for circumcision, and for this we have now included the age criteria. We have extended the age criteria to 6 months. We are going to monitor the complication rates. We are planning to develop an SCP app for electronic data entry. We plan to do outreach camps. 1 camp has already been conducted at Badin. We plan to train more health providers and to scale up to other suitable sites. Thank you.
Assalamualaikum, greetings everyone. This is Kulsum. I'm a PhD research fellow at Dr. Acute Institute of Biotechnology in Genetic Engineering, University of Karachi, and the title of my presentation is Association of Serum Vitamin D Levels in Vitamin D Receptor Gene with its Susceptibility to Coronary Artery Disease. Coronary artery disease.
Assalamu alaikum. My name is Dr. Wasfa Farooq, and I will be presenting my abstract titled Establishment of a Multi-Institutional Childhood Cancer Registry in LMIC. The World Health Organization launched a global initiative for childhood cancer in 2018 to achieve at least 60% 5-year overall survival for children suffering from the 6 most common childhood cancers by 2030. The current overall survival rate of childhood cancer in Pakistan falls somewhere between 30 to 35%. Unfortunately, national action plans remain missing despite resolutions, as major misconceptions persist worldwide. Not only is the burden of cancer in lower middle income countries incorrectly perceived to be significantly lower than higher income countries, their lack of resources and potential for development is often seen as a fruitless diversion of resources. The current projections based on the Global Childhood Cancer Microsimulation model in terms of access and referral estimates that a staggering 6.1 million cases of childhood cancer will be undiagnosed in 2020 to 2050 in LMICs, greatly exceeding those who are diagnosed. This fact is also what further encourages this perception of a greater burden of childhood cancer in higher income countries because there is greater diagnosis and greater documentation in those countries compared to lower middle income countries. Population-based cancer registries that are used to collect, store, and manage data regarding cancer patients, allowing authentic estimations of trends, provides an excellent means for observing the development in the cancer situation over extended periods of time. Unfortunately, low and middle income countries such as Pakistan are lacking in government level population registry efforts. There is currently no cancer or childhood cancer population level registry combining hospital data with public census statistics in Pakistan within any organization. Therefore, the Indus Hospital and Health Network, with the help of the My Child Matters or MCM grant, which was awarded by the Sanofi Espoir Foundation to Dr. Shampal Ashraf at Indus Hospital, established a comprehensive hospital-based childhood cancer registry since 2016. 8 pediatric oncology units enter their childhood cancer data into the IHHN hospital-based registry via trained data operators using a standardized ICD-03 coding system. Centers that are participating in the IHHN registry include Indus itself, TIH Kranji campus, NICH, which is National Institute of Child Health in Karachi, Children's Hospital Multan, Children's Hospital Faisalabad, Mayo Hospital Lahore, with its pediatric units 1 and 2, Lahore General Hospital, Services Hospital Lahore, and a recently enrolled center in PIMS, Islamabad. The total number of cases that have been entered into the childhood cancer registry run by Indus Hospital so far, which is managed by the Electronic Medical Record or EMR department of Indus, is 8,557, with the highest percentage of cases presenting to Indus Hospital itself, which make up around 60.3% or 5,160 cases. The gender distribution of registered cases shows a male predominance at 64.2%, and the abandonment rate seen within our data was 14.3%. These are patients who have left or had a gap of 4 weeks or greater in their treatment. Alive with disease and on treatment patients are currently 40.7%, and expired patients within the entered data are 16.9%. The results of the types of cancers shows leukemias at 46% with the greatest number of cases, followed by lymphomas and abdominal tumors. Then retinoblastomas and sarcomas around the same percentage and frequency, along with CNS tumors. Bone tumors stand at 4%, and other rarer types of cancers such as HLH, LCH, among others, stand at around 1% of the total burden of cases present in the childhood cancer registry. If we look at area-wise distribution across the country, we see that within Indus Hospital, the greatest number of cases presenting are from interior Sindh, followed by Karachi and Balochistan. Then we have Punjab and KPK. Afghanistan has been included in this figure because despite not being a province of Pakistan, a very large number of patients are seen coming in from Afghanistan because of the unfortunate lack of childhood cancer services within their country. Developing standards of cancer registration and standardized definitions of quality criteria are essential prerequisites for international comparisons. However, comparability requires that all of the cancer registry always apply the latest version of the diagnostic classification system and not resort to older versions. This is an extremely important point because the reason why national efforts and population level registries with a government dedicated resources are essential is because the data that is often collected from various centers, especially within Pakistan, is not present in a standardized format, and it requires a lot of extra effort and funding and resources dedicated to this data collection and standardization process that allows the data to be entered into one registry, which if done on a national level with other centers with different types of that employ different methods of data collection, it will require a very large scale and a very dedicated national action plan that will be able to standardize all of this information onto one platform. Greater number of cases need to be documented in registries across the country for deeper understanding of disease incidence, outcome, and identify areas in need of better facilities. It is extremely essential for childhood cancer data to be analyzed on a larger scale for deep learning purposes, because simply opening centers according to international standards and training doctors according to pre-decided curriculums does not encompass a holistic approach without understanding epidemiological trends of diseases. The cancer registry data is being further analyzed for overall survivals, along with demographic details of the patients whose cases have been updated and are currently still being updated with follow-ups and final outcomes. These are the references that were used in this presentation. Thank you very much for your time, and I look forward to any questions that you may have.
Today I'll be presenting the study titled Understanding Perception and Practices for Designing an Appropriate Community-Based Kangaroo Mother Care Implementation Package, a qualitative study in rural Pakistan. The principal investigator for this study is Dr. Shabina Arif, and the team members are as follows. As we know, a newborn, particularly one born preterm or with low birth weight, is vulnerable and requires special care. The prevalence of low birth weight reported in various studies in Pakistan range between 19 to 30%. Low birth weight increases the risk of infant morbidity as well as mortality rates. Kangaroo mother care is one of the low-cost interventions to care for these low birth and preterm infants. It has shown a 40% improvement in survival of preterm infants. However, despite the evidence of its benefit, the uptake and implementation of KMC is limited in developing countries, including Pakistan. The rationale for choosing community-based kangaroo mother care was that around 1/3 of births in Pakistan is home-based, and a big number of these births are conducted in rural areas. Secondly, there is limited resources to care for these preterm and low birth weight newborns. Most of the health facilities are either understaffed or they lack healthcare workers with neonatal training. Also, there is shortage of equipment, and if available, they are not functioning properly. All of this ultimately results in a higher neonatal mortality rate. The objective of our study was to understand the community and healthcare providers' views and practices on low birth weight and KMC in order to design and deliver a culturally appropriate KMC package in the community. To achieve our objective, we conducted a qualitative exploratory study using focus group discussions, in-depth interviews, and key informant interviews. Our study participants included community members, mothers, grandmothers, and fathers, and healthcare providers, including LHWs, LHVs, nurses, pediatricians, gynecologists, and taluka hospital administrators. The study was conducted in 3 talukas of rural district Dadu, Sindh, Pakistan. The interview guide was developed using a conceptual framework from a KMC formative study conducted in India. This interview guide contained questions regarding community understanding of preterm birth complication, their prevailing beliefs and traditional practices regarding newborn care, and specifically low birth weight newborn. There were also questions about existing social support system for mothers, the willingness of mother to provide KMC, and the willingness of community members to become KMC champions. The hospital administrators were asked about suggestions to KMC implementation at facility level and the role of healthcare workers in it. These guidelines were pilot tested in a village similar to our project area in terms of socioeconomic characteristics. 6 mothers, 1 community male member, and 1 grandmother participated in the pilot phase. Based on the results of pilot, interview guide was modified. We also developed a video and Kangaroo mother care for participants. It was recorded in their native language, which is Sindhi, and in a similar setting as the study sites. Data was collected by 6 data collectors, which included 2 LHVs and 4 social scientists. Consent was taken and all interviews were audio recorded. A quick glance on demographics. A total of 35 interviews were conducted, which include 18 FDGs, 9 in-depth interviews, and 8 key informant interviews. We interviewed 184 participants, out of which 23% were men and 76% were women. Their age ranged from 16 to above 50 years. The mean age of mother was 31.9 years, and for father it was 30.3 years. Data was analyzed using thematic analysis. Moving towards the study results, there were few themes that we got out from the studies. First one was community practices and perception on immediate newborn care for all babies and low birth weight babies. When we asked mothers and grandmothers if they were able to differentiate small babies from normal babies, the majority of mothers and grandmothers were able to do it. Almost 70% of the respondents were knowledgeable and they stated that these babies require special care. They referred their small babies as Kamzor, Satyara, or Ghatvazan Ba. Around half of the participants stated that they would give bath to their low birth weight babies either on second or third day of life. And in winters, they would delay the bathing up to 2 weeks or later. Exclusive breastfeeding was also not very common practice in the community. They usually give formula milk to their low birth weight babies for extra calories. Interestingly, they said that they would give goat milk to the babies, usually in the evening hours. Another common practice in the community was to give pre-lactal feed such as cardamom, grape water, and gutti to help baby in digestion. All of these traditional practices may serve as a barrier to implementation of KMC immediately after birth. When we explored about the thermal care, the respondents said that they would wrap low birth weight baby in cotton wool and blanket immediately after birth, and in winter they would place them near a wooden fire. They also give them sun bath to keep the baby warm. Now moving to second theme, which was community perception of KMC and willingness for kangaroo mother care practice. Family members and community members all showed willingness towards KMC using the local wrap, which was dupatta or chadar. But they had concern that baby might slip out of the wrap when they carry the baby and simultaneously do their house chores. Healthcare providers also showed positive response. They understood the benefits and were ready to support the implementation of KMC in their community. However, healthcare workers were not confident to teach KMC in the community. One of the LHV stated, and I quote, "We never practice it because of fear, and we do not know the steps of KMC." We showed each participant our KMC video, and after watching both community member and healthcare providers said that yes, KMC is easy, it's practical, and it would be beneficial for growth and well-being of their baby. We also inquired about the duration and feasibility of practicing KMC. Most of the mothers agreed to practice KMC on an average of 6 to 8 hours a day without any support. But they were reluctant toward practicing it continuously for 24 hours. They shared that it might cause backache if they hold the baby in the KMC position for longer hours, especially soon after the delivery. As Dadu is a very hot area, mother and grandmothers were also worried that practicing KMC may develop baby sweat rashes. The third and the last thing was integral support system in the community to foster KMC practices. An important finding and an enabler towards KMC practice is the cultural concept of chilla. Chilla is care of birth-giving woman immediately after the birth up to 15 to 40 days, which is the postpartum period. During this period, the mother and the baby died remains together and the mother is provided time to rest and recover. One of the grandmothers stated, during chilla days, woman is taken care of, she's provided food, and she does not do anything but rest till 21 days. This support system during chilla period would largely facilitate an implementation of KMC practice in the community. All family members such as grandmother, father, sister-in-law, mother-in-law, everyone showed willingness to assist mother in KMC, either providing skin-to-skin contact to the newborn or helping mother doing household chores. Community members play an important role in our community. When we interviewed them and showed them the KMC video, they were very inclined towards KMC and agreed to assist in creating support group and counsel community for KMC. We also carried out a pilot study with 9 mothers to evaluate mothers' experience of providing KMC with their local rep. We used a long cotton dupatta for this activity. When mothers were asked about their views, they said it was easy to use, it was comfortable, and they felt happy and peaceful to carry their newborn on their chest. Finally, to conclude, KMC is widely acceptable in community to improve low birth weight neonatal outcomes. However, adoption of KMC can be facilitated but would require assistance and counseling from healthcare providers and community healthcare workers. Thank you.
Assalamu alaikum. A very good morning to everyone. I'm Khushbu Kaimali, working as a research coordinator at Aga Khan University Hospital, Department of Pediatric and Child Health. The title of presentation is Diagnostic Accuracy of Point of Care Ultrasound compared to standard of care methods for endotracheal tube placement in neonates. The primary investigator of this study is Dr. Shabina Arif, Associate Professor at Aga Khan University Hospital, and co-PI were Professor Sajid Basir Sufi from Aga Khan University Hospital, Dr. Hassan Mirali, Dr. Mark DeSero, Dr. Sean Morris from Sikkim. The study was funded by Grand Challenges Canada and collaborated by Sikkim. Just a brief intro about point-of-care ultrasound focus. Focus is a powerful tool used in neonates for several diagnostics. It is a fastest approach and can be helpful for identification of endotracheal tube placement, then current standard of care methods, which includes auscultation, capnography, and chest X-ray. In children, the sensitivity and specificity for focus endotracheal tube placement is 98.9% and 94.1% respectively. Focus has been already used in stable intubated NICU patients for identification of ETT depth. However, there are only few studies that have compared the use of focus for ETT placement and compared with standard of care methods. So the study actually fulfilled the gap. The primary aim of the study was to evaluate the diagnostic accuracy of focus compared to standard of care methods in neonates. Moreover, it also compared the time to interpretation for correct identification of endotracheal tube placement with standard of care methods. This was a cross-sectional study and was conducted in an ICU neonatal intensive care unit at Aga Khan University Hospital, Karachi. We included all newborns that required intubation either in NICU or labor room OR. The endotracheal tube placement was determined using standard of care methods, as we already discussed, auscultation, capnography, and chest X-ray by a clinical team. Simultaneously, a POCUS user who was a trained healthcare professional performed and interpreted the images in a real time. The POCUS images were then shared with and interpreted by POCUS expert at Sheikh. Everyone, including clinical team, POCUS user, POCUS expert, they all were actually blinded with each other's assessment. The timings were recorded for each method by a research staff. So, a Philips Lumify USB ultrasound unit that was used as shown in the image as well. The L212 linear array transducer was used with a set of depth 2.5 centimeter and was connected with Android version 4.5 tablet computer. We actually provided two machines, one in NICU, another in LR1. So finally, the results. A total of 348 neonates were enrolled in the study, and the mean gestational age of newborns was 32.6 with a standard deviation of plus minus 4.8 weeks. More than half, 58% of intubations were in an emergency scenario. The major reasons of emergent intubation includes hemodynamic compromise, 31.2%, respiratory failure, 29.7%, and administration of surfactant, 20.8%. The most common medical diagnosis was respiratory distress syndrome, which actually accounts for 57.2% in neonates. Using an expert as the reference standard, POCUS user interpretation showed 100% sensitivity and 94% specificity. We found a 99.4% agreement with kappa 0.96 and significant p-value between the POCUS user and expert. Diagnostic accuracy of POCUS was compared with at least two standard of care methods, and that demonstrated 99.7% sensitivity and 91% specificity with 98.9 agreement and significant p-value. The median time required for POCUS interpretation was 3 seconds compared to auscultation that accounts for 6 seconds and capnography for 3 seconds. To conclude, point of care ultrasound is a rapid method for identifying in compared to standard of care methods. It is faster than auscultation and chest X-ray. So, early and correct identification of airway management is critical, as we all know, to save lives and prevent mortality and morbidity. So, these are the references. Thank you.
Hello, everyone. This is Mohammad Aftab Gohar, Manager Rabies Prevention Training Center of the Indus Hospital, Karachi. Focus of my presentation today is how to make rabies post-exposure prophylaxis economical in Pakistan. Rabies is basically a zoonotic disease which is transmitted through infected animal, mainly through rabid dogs, and children are at higher risk as they are vulnerable to get dog bites on the street. Rabies is 100% fatal and yet 100% preventable as well if a dog bite victim is managed timely and effectively according to the WHO set guidelines. Rabies is transmitted through bites or scratch of a rabid animal, and from 6 weeks to 6 months, it gets into the brain, and symptoms start with fever, headache, periods of mental confusion, and further deteriorate to hydrophobia, anerophobia, or sometimes photophobia. Once symptoms develop, it becomes irreversible. The patient dies with a very, very painful way. This has become very common now that you see street dogs are everywhere now, and they are increasing every day. Here's the states of dog bite victims seen at the Indus Hospital, Karachi, which shows patients are increasing remarkably every year. And we have managed more than 50,000 of dog bites so far and given them post-exposure prophylaxis according to the WHO guidelines, where none of them got rabies after the PEP. And here you see almost half of them were category 3 and category 2 bite victims. This is really disturbing. I'm showing you a few of the patients seen at the Indus Hospital got severe wounds at face, head, neck, arms, and everywhere in the body. Why are dog bite victims dying of rabies? One of the very main reasons is inadequate knowledge of post-exposure prophylaxis among the healthcare workers, and the poor knowledge, attitude, and practices of rabies vaccine and immune globulin. It is important to understand the vaccine used to be given in the abdominal wall. The 14 injection has been obsolete many, many years back, and it does not exist even in the history book. So no more 14 injection into the abdominal wall. Advanced cell culture vaccine was introduced in 1970s. Initially, it was given intramuscularly only, and then Red Cross intradermal, which is a low-dose vaccine regimen introduced in 1980s to make post-exposure prophylaxis cost-effective, and the number of doses further reduced in the following years. Here we have a state-of-the-art rabies prevention center of the Indus Hospital, Karachi, where PEP is uniformly practiced according to WHO latest guidelines. We are also a training center for rabies post-exposure prophylaxis, where we train doctors and nurses and help them to establish post-exposure prophylaxis clinic in their respective health facilities. Dog bite or any animal bite that can potentially transmit rabies should be immediately washed with soap and water for at least 10 minutes, which reduces amount of virus from the wound. Apply disinfectant, but do not suture the wound immediately. Proper and early wound washing can reduce chances of developing rabies by 30%. This should be taught to the patient and family and to the general public, so that wound washing should be done ASAP wherever it is possible. Based on WHO guidelines, there are 3 categories of victims in terms of severity of wound. Category 1 is just touching or feeding of animal or licks on intact skin. This is a known risk category where it is considered a known exposure. Category 2 is minor wounds without bleeding, in which vaccine series is given. Category 3 is single or multiple deep wounds with bleeding, where immune globulin is also given along with first dose of rabies vaccine. Vaccine must not be given into gluteus. It should be preferably given into deltoid. Intradermal gives equal immune response as intramuscular vaccine does. As per WHO advanced recommendation in 2018, rabies immune globulin, which is essential in category 3 wound, should be infiltrated only into wound, or if there are multiple wounds, so it should be infiltrated into all wounds, but not into the muscles. As far as vaccine is concerned, intradermal regimen should be given 3 doses in 1 week on day 0, 3, and 7, and IM regimen should be given on 4 doses on day 0, 3, 7, and 14. There is a misconception that PEP is very expensive In 2015, we did a publication in an international journal on reducing cost of post-exposure prophylaxis at the Indus hospital. The study was done among 2,300 patients presented to Indus Hospital, Karachi between 2013 and 14. Given vaccine to 2,300 patients with intradermal regimen, it cost us around 1.3 million. And it would have cost about 6.3 million if intramuscular regimen was used. And this way we saved nearly 50 lakh rupees in a single year just with vaccine. Cost of immune globulin, equine immune globulin that was used to give in these patients in category 3 patients was about 1 million rupees. The accumulated cost of vaccine and equine immune globulin was around 2.3 million. And on average, it was just about 1,000 to save a life. I think we consume a lot in other ways, like in giving antibiotics and so on. So to save a life, this is really nothing. In addition to what I've already shown, the cost reduction by using intradermal regimen, we made another publication last year which shows further reduction in the cost of PEP by following the WHO latest recommendation on PEP in 2018, which gives the equal quality treatment and save life from rabies in a 100% preventable manner. Messages for public, for policymaker and decision makers: establish post-exposure prophylaxis centers in district hospitals with dedicated wash area, training of doctors, nurses for PEP, 1 week intradermal vaccine regimen. If 2 or more victims within 8 hours come to the facility, infiltration of all deep wounds with equine immune globulin, which is a life-saving drug and essential in all category 3 wounds, sustainable supply of quality vaccine, sustainable supply of equine immune globulin. Rabies is preventable. Awareness and education in both healthcare workers and general public is the key. Thank you so very much for your attention. Thanks a lot.
Assalamualaikum, greetings everyone. This is Kulthum. I'm a PhD research fellow at Dr. Acute Institute of Biotechnology in Genetic Engineering, University of Karachi. And the title of my presentation is Association of Serum Vitamin D Levels and Vitamin D Receptor Gene with its Susceptibility to Coronary Artery Disease. Coronary artery disease is a leading global cause of mortality. It is caused by a condition called atherosclerosis, which reduces the blood flow towards heart. There are different risk factors that are involved in the development of coronary artery disease, defined as modifiable and non-modifiable risk factors. Among non-modifiable risk factors, such as age, gender, and family history of coronary artery disease conditions, plays a huge role in the development or the risk of this disease condition. On the other hand, 70% of the risk factors attributed with coronary artery disease are potentially modifiable, including hypertension, diabetes, obesity, and one of the risk factors which has gained attention recently is the deficiency of serum level of vitamin D. Vitamin D, which has always known for its classical role in calcium homeostasis and the regulation of immune and hormonal function. But vitamin D levels are also important in maintaining the normal physiology of myocytes. For example, there are multiple functions that vitamin D used to play towards heart, including the growth, proliferation of cardiomyocytes. It plays important role in increasing the expression of cardiac protein, which is myotrophin. Further, vitamin D is also involved in decreasing the level of matrix metalloproteinases, interleukins, for example, interleukin 1, interleukin 6. It also reduces tumor necrosis factor alpha and advanced glycation end products, which has a deleterious effect towards heart. It also upregulates the expression of interleukin 10, matrix gamma carboxyglutamate protein, and type 4 collagen. So the mechanism of action for vitamin D complex includes the active form of vitamin D binds with vitamin D receptor in order to regulate the transcription of different genes. However, if either there is low level of vitamin D or alteration in vitamin D receptor, there will be no binding, and it might also lead to the dysregulation of transcription of different genes, which induces the different diseases condition. On the basis of above literature, the aim of this study was to investigate association of vitamin D receptor gene and serum level of vitamin D with its susceptibility to coronary artery disease. There are different polymorphism found in vitamin D receptor genes, including tag polymorphism. And in this study, tag polymorphism was selected based on its previously defined implication on gene expression. This polymorphism is found in exon 9, and it has been found to affect the stability of mRNA, which is assumed to cause alteration in vitamin D receptor. It has been found to be associated with different disease conditions like cancers, diabetes, and reduced level of serum vitamin D level. Before commencing the study was ethically approved from IRB of 2G and its respective hospital and ICVD, where the samples were collected. The inclusion criteria involved diagnosticians of coronary artery disease, which were matched with age and gender matched healthy individuals in order to do a case control study. On the other hand, the patient other than coronary artery disease were excluded from the study. All the samples were taken from these subjects with informed consent, and the sample size include 516 patients compared with 500 controls. The methodology involved DNA extraction from the blood samples followed by sorting out method, which were further followed by quantitative and qualitative analysis for checking the concentration and integrity of DNA. Later, the DNA was used in order to amplify the targeted sequence using allele-specific PCR, and the genotyping were visualized on 2% agarose gel electrophoresis. Samples were then purified for DNA sequence analysis, and the results obtained were observed statistically by using different statistical and bioinformatics tools. The results were categorized into three categories: demographic classification and biochemical and genetic analysis. Age and gender distribution were observed among subjects, and the age of participants were observed between 30 to 89 years, where most of the participants were between 50 to 59 years old. Different distribution of risk factors were also observed, and it was found that their patients were having history of different disease conditions like coronary artery disease, diabetes, hypertension, and others. Clinical parameters were also observed, and it was found that cases having slightly higher values in the normal ranges. Serum vitamin D levels were observed using ELISA, and we found that the serum vitamin D levels were significantly lower in coronary artery disease patients as compared to controls. The genotyping of TAC1 polymorphism in vitamin D receptors were achieved by amplifying using allele-specific PCR, and it was visualized on 2% agarose gel electrophoresis. Here in lane 1, we can see the presence of P genotype, which is a wild type, and the presence of C allele, which is a variant genotype of TAC1 polymorphism, were observed among patients, which were represented by the successful amplification of 148 base pair size band on agarose gel electrophoresis. The genotype distribution were observed among cases, and we observed that the T genotype, which is a wild type, it was more common in healthy controls as compared to cases. On other hand, the presence of heterozygous genotype condition, which is a variant genotype, were more common in our patient as compared to controls. Gender-based genotype distribution were also observed among patients, and we found that both homozygous genotype, either wild type TT or wild variant C genotype, were more common in females as compared to males. On other hand, male were highly prevalent, having the variant heterozygous genotype as compared to females. Allelic frequency for type 1 polymorphism observed in patient and control, which represented that T allele wild type were more common in controls as compared to cases. On the other hand, the C allele, which is a variant genotype, were more common in cases as compared to controls. Multiple sequence alignment were also performed on our sequence samples, which were compared against the wild sequence retrieved from genomic database, and we found the presence of both wild type and variant uh, mutation in our samples. The DNA sequence analysis for type 1 polymorphism for wild and mutant variant were also observed using chromatogram. And here, the presence of red peak is representing the presence of wild type, and the presence of blue peak is representing the presence of variant genotype. The association analysis for type 1 polymorphism were also calculated by chi-square and Oyster-Show, and we found that the variant C allele was significantly associated with the disease condition, and the individuals having variant C allele were 1.84 times more susceptible to disease condition as compared to patients as compared to individuals having T allele, which is a wild type. So on the basis of the above results, we concluded that calcitriol, which is active form of vitamin D, along with vitamin D receptor, plays important role towards maintaining normal physiology of cardiomyocytes. We found that the serum level of vitamin D were significantly lower in patients as compared to controls, and the genotype association were also found significantly associated with the disease risk. We also found that the variant C allele cause 1.8 times more risk and susceptible condition towards disease as compared to individuals who have a wild type allele. And in the end, we can conclude that the presence of genotype condition, which is type 1 polymorphism in vitamin D receptor gene, along with the reduced level of serum vitamin D levels, are contributing towards the development of disease risk of coronary artery disease. These are the references used in making of this presentation. In the end, I would like to thank you all for your attention. Thank you.
Assalamu alaikum. I'm Dr. Farhana, and I'm assistant professor at Aachen University Hospital. The title of my study is Awake Proning in Patient with COVID-19, and these are my co-investigator. Severe illness characterized by progressive apocrine respiratory failure develops in large number of patients with COVID-19 that results in prolonged ICU stay, invasive mechanical ventilation with profound effect on morbidity and mortality. Prone positioning has been shown to improve the oxygenation for decades, and majority of the cases it has been applied in patients with ARTS and who are on mechanical ventilation. However, proning in awake, non-intubated patients gained widespread acceptance and popularity since the onset of current pandemic. There's a limited evidence about the efficacy of conscious prone positioning without invasive ventilation COVID-19 patients who has hypoxemia. The objective of current study was to evaluate the efficacy of awake prone position in hypoxic, not intubated patients with COVID-19 within this geographical area. The primary outcome was avoidance of intubation, and secondary outcome were in-hospital mortality and the length of hospital stay. We had conducted a prospective observation study of adult patients admitted with severe and critical COVID-19 between July to September 2020. Patients received awake prone position early on after admission as a part of their treatment strategy, along with the standard of care. They were compared with those who received standard of care alone. The assessment for initiation, frequency, and duration of each session of proning was based on the assessment of primary physician as well as respiratory therapist. We took patients' informed consent as well as patient cooperation and tolerance was also considered before starting this maneuver. The patient who were not able to receive prone position due to some reasons like contraindication for prone position were there, or patient was not able to tolerate prone position were included in the control group. Patient received prone position with invasive mechanical ventilation were excluded from the study. A total of 98 patients with COVID-19 treated with awake proning were compared with 98 patients treated with standard of care alone. The mean age of patient awake prone group was 56.9 years, while mean age in control group was 55.7 years. Majority were male in both groups. There was the more frequent comorbid illness in both groups were hypertension, diabetes, and ischemic heart disease. Critical COVID-19 was present in 50% of patients treated with prone position, while 35% patients managed with standard of care alone had the critical illness. The mean duration between admission and initiation of prone position was 3 days. The median days of proning were 4 days. The minimum number of hours of awake proning tolerated by patient were 2 hours per day, and maximum hours tolerated were 16 hours per day. There was no major complication related to awake prone position was reported during the study period. Among radiological findings, there were predominantly bilateral lung infiltrate on chest radiograph in both groups. However, a comparatively high number of patients presented with multilobar lung involvement in prone groups as compared to those who treated with standard of care alone, with a p-value of 0.001. Although the mean PF ratio at the time of admission was significantly lower in patients treated with awake prone position as compared to control group, but with the passage of time, both groups have shown significant clinical improvement in PF ratio by the time of discharge. The median length of stay in his special care was comparable in both groups, that is 4 days. The median length of stay in the hospital in both groups was also comparable, that is 8 days for prone position group and 7 days in control group. The use of awake prone position did not reduce the risk of intubation, invasive ventilation. 8.1% patient in prone group and 5% control group required intubation, and that difference did not reach statistical significance. The overall mortality in the study the overall mortality among the study participants was 10.3%, and which was similar in both groups. The cause of that in majority of the study participants was ARDS, followed by septic shock and multi-organ dysfunction. ARDS leading to death was more common in patients who were not treated with standard of care alone as compared to those who received prone position ventilation with a p-value of 0.02. In conclusion, awake prone position can be considered as a safe, cost-effective, and adjunctive therapeutic option that has shown to improve the oxygenation in patients with COVID-19. It may slow the respiratory deterioration in selected patients with COVID-19 who require oxygen supplementation or non-invasive ventilation. This in turn may reduce the demand for invasive mechanical ventilation, thus helps in reducing the pressure placed on intensive care services around the world. It may not successfully prevent all intubations, and its impact on other clinical outcomes like survival and duration of hospitalization is uncertain. It can be included in home-based management protocol of COVID-19, and it helps in decreasing the burden on healthcare facilities, especially in resource-limited settings. Thank you so much.
Assalamu alaikum. I'm Dr. Sabah Shahid and I head the pediatric department at the Indus Hospital, Karachi. I'm thankful for the ID department to invite me as a speaker for the ICON conference. I would like to share my presentation I did on COVID in patients with malignancy. I will share my slide with you. And as you can see, the title of the study was Comparison of Clinical and Diagnostic Features of Pediatric Oncology Patient with or without COVID infection. It was a retrospective chart review. I had other co-authors whom I'd like to acknowledge. Okay, so this, the background was that in February, we started getting a lot of COVID patients in February 2020. And we set up a COVID ward, which comprised both of adults and a 10-bedded pediatric ward. The ward was shared equally by malignant children and non-malignant children. So this was the time also when we decided to have our own institutional guideline based on the literature which was internationally available. As a policy, we decided that we will screen children on clinical grounds as well as on the basis of CBC initially, because it was a cost-effective intervention and almost all the children were having their CBC done. So at this time, my colleagues who were treating pediatric oncology patients, they referred to us for their patients as well. What we realized at that time was that the clinical manifestations and the CBC and hematological indices were not actually the same for oncology patients. And this was anticipated because the oncology patients, many of them have infections because of infections other than COVID, and also because of chemotherapy side effects. Also, the CBC and the neutrophil lymphocyte count and the ratios like NLR and LMR are different in these patients because they tend to have higher leukocyte counts. They tend to have neutropenias, lymphopenia. So we realized that we needed some benchmark to do disease stratification and for disease monitoring. So this was the reason we started doing this retrospective chart review. So the period was from March to June 2020. And this was the electronic records were pulled from the HMIS of our hospital and a chart review was done. We collected the final outcomes of the patient after 14 days of infection. So some of them we gathered information from on phone, while some of the children were admitted with us in the hospital. We also tried, before starting the study, decided on disease severity criteria. These criteria were based on what was done internationally. And these, if you can see that we thought we categorized the severe disease and there were 2 or more following manifestations present, which was SpO2 less than 90% in room air, presence of multi-organ dysfunction, or pediatric acute respiratory distress syndrome, presence of severe pneumonia, shock, or missing. One thing I would like to mention here is that for the PARDS ratio, there are 2 markers which can be used. It can be either SF ratio or PF ratio. PF ratio uses PaO2, which is derived from the arterial blood gas, whereas the SF ratio relies on SpO2, which is done from the pulse oximeter. It was more cost effective for us to use the SF ratio because not many children were having arterial blood gases. So the SF ratio, which is a surrogate for PF ratio, we adopted that for monitoring PARDS in our study. So I would like to share the demographic results in this slide. Total, we have 73 COVID positive patients and 75 COVID negative patients. We did not observe much difference in when it came to gender or the mean age or the type of malignancies. We saw more children having leukemia because actually this is the kind of malignancy we commonly get more as compared to solid organ tumors. Then when we saw the disease severity, asymptomatic infection were noted in 44 children, while unknown outcomes or mild infection were present in 20. Severe disease was noted in 9, out of which 5 succumbed to the disease and expired. Interestingly, the other manifestations like presence of fever, flu, malaise, and other GI upsets were quite similar in both the groups, so I did not mention them here. Which was different was presence of cardiac and pulmonary manifestations. Cardiac dysfunction was present in 4 COVID patients, whereas only 1 child in COVID negative group had a cardiac dysfunction, which was also related to the chemotherapeutic drug. ARDS was present in 6 of our COVID positive cohort, while COVID negative cohort did not have any PARDS at all. When you look at the lab investigations, we had some interesting results. When we look at the TLC or total leukocyte count, we do anticipate a higher value. And 21,000 is on the upper side of the TLC count. But what we saw was that in malignancy patients with COVID, the TLC was even higher. Then normally, if you look at this COVID negative group, this is what we do actually see in malignancy children. They tend to have leukopenia and lymphopenia. So if you see that COVID negative children here, they had absolute neutrophil count less than 500. And they also had lymphocyte count less than 2,800, which is the normal response we see in COVID patients because of chemotherapy or by the virtue of their malignancy. But the COVID positive group, they have neutrophilia and lymphocytosis when compared to their COVID negative counterpart. This was also seen in the ratios. We have to be cognizant of the fact that the neutrophil lymphocyte ratio or LMR or PLR ratio, they are all derived from the absolute values. So the NLR ratio, if you see that the neutrophil count is directly proportionate to the LNR ratio, and the lymphocyte count is directly proportional to LMR ratio. So what we see here that the NLR ratio was low in COVID negative patients, was higher, I'm sorry. The NLR ratio was higher in COVID negative patients, but it was low in the COVID positive patient. And why did this happen? This happened because the lymphocyte count was higher, significantly higher in the COVID positive group as compared to COVID negative counterpart. This caused the ratio to be reversed. So the NLR ratio in COVID negative was actually 2.9 and 1.78 in COVID positive. Similarly, the lymphocytosis was much higher in COVID positive group, which caused an increase in LMR ratio in COVID positive group when it was compared to COVID negative. The PLR ratio was also raised, but not significantly raised. If we see this, this is what is which is represented in graphically also, that both groups, positive and negative groups, had malignancy. But if you look at the ratios and the absolute leukocyte count, then we see that the ALC, the LMR ratio, and the PLR ratio, they show the trend towards rise when we came to the COVID positive group. Whereas the NLR ratio, it declined when we moved towards the COVID positive group. So what does it actually tell us? It tells us that if we were to suspect COVID infection in a patient with oncology, looking at CBC might actually help us. If there is rise in leukocyte count, or if there's rise in lymphocyte count, then it may suggest a possible COVID infection. And if you look at the ratios, then a falling NLR ratio and a rising LMR ratio may suggest that child may actually be having COVID infection. Then the clinical features, many of the clinical features were similar, so I did not mention them here. But the interesting things which came up in the study were actually three things. First was chest imaging. The chest imaging findings, which comprise of either chest X-ray or HRCT or both, were actually similar in both the groups. So these children, but if you look at the ARDS, then none of the children in COVID negative group had ARDS, while the 6 children who had ARDS in COVID positive group clinically also had severe disease and severe COVID pneumonia, while their chest X-rays did not support that. So, and then if you look at the echocardiography, then the cardiac dysfunction, which was LV dysfunction or reduced ejection fraction, was more in COVID positive group. So this led us to an interesting finding that children with COVID pneumonia may actually have an initial difference of the ARDS or SF ratio, and the chest imaging findings may develop later. Then when we looked at the time which was taken to get a negative PCR, this is actually no news because a lot of us by now know that in oncology patient, it is actually a problem that their PCR clearance is not comparable to that of normal children. We saw 19% children whose PCR cleared within after 14 days. And 7 and 3% children required 21 or 28 days to clear off their PCR report. This, by the findings of our study, we then revisited our policy, and then we started repeating PCR after initial infection, after 3 weeks of an initial infection. And then after 3 weeks, we allowed them to come to daycare to get their chemotherapy with proper precautions. And this was also noticed worldwide that the children may not be infective, but they may still have positive PCR for longer period after initial infection in oncology. So the final outcomes we saw were that 38 children got cured, 21 were advised home isolation, 9 were either referred out or left against medical advice, and 5 succumbed to the illness. So finally, I come to my last slide, which is what were the lessons we learned. The lessons we learned was that as children without malignancy, children with malignancy also tend to have milder infections. The majority are asymptomatic, and they do not require treatment. When it comes to blood cell indices, their absolute values as well as the hematological ratios differ from children without malignancy. Decreased NLR and rising LMR ratio may suggest that child may have COVID infection and may also predict that child may have the severe disease course. Then children who have malignancy and COVID, SF ratio may be an early marker to predict that child may develop COVID pneumonia. So imaging findings may differ or may develop later, but SF ratio can suggest early presence of pneumonia among pediatric oncology patients. I thank you very much for your time and patience, and I hope that with this study, I will be able to add some insight into the pediatric COVID infections with malignancy. Thank you very much.
So welcome back, and so let's move on to the results for the oral presentations and e-posters. So I'll be announcing the results of oral presentations first. The first prize goes to the oral presentation as titled as Outcome of COVID-19 in Renal Failure and Tolerance of Remdesivir, Experience from a Large Renal and Dialysis Center from Pakistan. The second prize goes to Understanding Perceptions and Practices for Designing an Appropriate Community-Based Kangaroo Mother Care Implementation Package, Qualitative Study in Rural Pakistan. The third prize for the oral presentation goes to Association of Serum Vitamin D Levels and Vitamin D Receptor Gene with its susceptibility to coronary artery disease. So congratulations to the winners of the oral presentations. Now I would like to move on to the results for the e-posters. The winner for the first prize goes to Trends of Voluntary Non-Remunerated versus Replacement Blood Donations and Prevalence of Transfusion Transmissible Infection at various sites across Pakistan. The second prize goes to Prevalence and Factors Associated with Successful Weight Loss Maintenance among UA University Community. The third prize goes to Incidence and Root Causes of Surgical Site Infections among patients admitted in a tertiary care settings, Karachi, Pakistan. So if there are any queries regarding these e-posters and oral presentations that can be asked by the attendees and answered by the authors in the question answer box given below. And with this, also the results, we will be sending the emails to the winners, and we will be shortly telling you regarding how will you be able to get your prize monies on the emails. That will be basically on the closing ceremony that will be announced later, the date of which will be announced later, and we will inform you through the emails. So with this, I conclude this session with a special thanks to our scientific committee, our judges, and all the authors for their contributions in the ICON 2022. Congratulations, once again, congratulations to all the winners. Thank you. Allah Hafiz.